Hi, everyone, and welcome to USDTL's ToxTime titled Reducing Bias in Healthcare Starts with Destigmatizing Language. Our presenter today is Guida Brown, and she has had a degree in journalism and management, has had a career in Kenosha County nonprofit sector. She served as the executive director of the Hope Council on Alcohol and Drug Abuse for over 13 years. Guida has also worked at AM Community Credit Union and Women and Children's Horizon. She's been an adjunct faculty member at several universities and currently runs Guida by Guida while holding certifications in substance abuse counseling and other related fields in Wisconsin. Please note that the opinion presented in the session are those of the presenter and do not reflect any official policies or positions of USDTL. So now let's get started with our discussion, and without further ado, I present to you Guida Brown.
Hi, I am Guida Brown, the principal for Guided by Guida. Thank you for attending this ToxTime on reducing bias in healthcare starts with destigmatizing language. To start, we have to agree on a definition, or none of what we're discussing is going to register. So addiction is a chronic but treatable disease involving changes to circuits involved in rewards, stress, and self-control. I want to start with a story about two different men. So the first guy, he had 7 OWIs, and as part of my employment, I used to do assessments of impaired drivers. In Wisconsin, we call a drunk driver operating while impaired, OWI. He had 7 OWIs, and I said, do you realize that you have the disease of addiction? And he said, well, I don't know that I have a disease. I know I shouldn't be drinking. And I said, oh, okay. I looked you up on CCAP. In Wisconsin, we have CCAP, which is all the circuit court arrests. Every arrest made in Wisconsin that's going to end up in a circuit court shows up on CCAP. And I said, I looked you up on CCAP, and you have quite a few offenses. And he said, yeah, I've got 32. I said, well, I didn't count them, but you had a lot. And he said, yeah, I counted them. I've got 32. And I said, okay, so could you tell me that any of your offenses occurred because of your use of alcohol or other drugs? And he said, ma'am, I'd be lying if I told you any of my offenses didn't occur because of my use of alcohol or other drugs. I said, oh, okay. So if you knew before ever picking up, if you knew the problems that your use was going to cause you, would you have picked up? And he said, no, I wouldn't have picked up. Okay, then are you sick or are you stupid? And he said, well, when you put it like that, I guess I'm sick. And to me, he was probably the saddest client I'd ever worked with, because here's a guy walking around with a chronic, progressive, lethal disease that he doesn't know he has, because society, his family, himself have never identified it for him. And yet he could die from this disease he's walking around with. And I want you to contrast that to another guy I assessed. He had 2 OWIs. And I said, at the end of my assessments, I always say, is there anything you want to tell me I didn't ask you? And he said, yeah, I'm done. I'm done. If I had cancer, I would be looking for the best doctors and the best treatment. And so that's what I'm going to do here. And I wanted to take his picture, and I wanted to hug him, and I wanted to put the picture up as sort of the poster child of the agency, because we never have anybody identify addiction as a chronic, progressive, lethal disease, right? It's just like cancer. It's just like heart disease. It's just like diabetes. And unfortunately, it's the one disease it's the one disease that as a society we don't acknowledge as such. So again, in order to move this conversation forward, we have to all agree that addiction is a chronic but treatable disease. Bias can come about in a lot of different ways. So bias is a tendency to believe that some people, ideas, or whatever are better than others, usually resulting in treating the other unfairly, but not always. So bias isn't either good or bad. It's just believing that something is better than another. So I can have bias towards something, right? We hear about recency bias, or bias in hiring, bias in how we treat people. We know that we tend towards people who look like us. That's a bias, so that's a good thing. but obviously treating somebody unfairly because we have a bias towards the other side is where bias comes in as a bad thing. Next up, we have stereotypes. Stereotypes are oversimplified images of a group. They're shortcuts, and so they aren't really good or bad. They're ignorant. And there's a link at the end here that this Adichie talks about. It's 18 minutes. It's well spent. She talks about stereotypes are the danger of stereotypes is that it's a single story creates stereotypes, and the problem with stereotypes is that not that they're untrue, but that they are incomplete. They make one story become the only story. So we have stereotypes about characteristics, as in appearance, behavior, beliefs. Stereotypes about individuals or other groups. So we have stereotypes about dogs. All pit bulls are bad. All Shih Tzus are stubborn. All beagles bark a lot. I don't know. I mean, so stereotypes, again, not necessarily good or bad, just incomplete. The first time I remember being part of a group that was being stereotyped was when I was probably about 9 years old. And I went to church with a friend of mine. I was raised Catholic, Roman Catholic, and she was not. And we were at her church, and I was bored by what appeared to be a 100-year-old man singing, a 100-year-old man in my little 9-year-old brain. And he was singing, and I was misbehaving and, rolling my eyes and what have you. And my friend looked at me and said, "Well, at least he's not chanting in Latin." And I had absolutely no idea what she was talking about. And I didn't realize that I was being insulted or that there was a stereotype going on here because I was born the same year that Masses stopped being said in Latin. So I didn't know that that was her way of classifying me, classifying the Catholic faith as everybody chants in Latin. So again, not that they're untrue, just that they are incomplete. So next up, we have prejudice. We can be prejudiced towards or against something, as in blacks are good dancers, Asians are good at math, Mexicans are good workers. Or we can believe that Mexicans are drug dealers and blacks are criminals and Asians don't speak English. Again, prejudice can have prejudice either way. It's an attitude, opinion, or feeling formed without adequate knowledge, thought, or reason. It can be a prejudgment for or against. And then we think of discrimination. Discrimination can be positive. I have discriminating tastes. But most often we think about discrimination as being differential treatment of persons according to a particular group to which they belong. We tend to think of that as negative, and we think of it in workplace terms. So we discriminate based on sex or pregnancy or race or ethnicity or religion or abilities. Again, can be wrong. It isn't always, because we make, again, a shortcut to make a decision. We can't have somebody in a wheelchair trying to run a race. We discriminate, we make a decision, we treat that person differently. In that case, it could be good. I mean, obviously we want the person to be able to participate, and so that brings in a lot of other issues of equity, but we're still going to discriminate. We're still going to make a decision and have differential treatment. And then we have to think in race. In terms of race, we used to say that there were only 3. Now the US government says that there are 5, and there are other counts I've seen from 7 to 30. Or we can consider, as some scientists do, that race is a social construct and that there's only one race, the human race. So racism is the oppression of one race by another. For example, the oppression of blacks by whites. But the critical element differentiating racism from prejudice is the backup of institutional power. I, as an individual, can be prejudiced. I can't by myself be racist unless I've got the power of the system backing me up. I'm not saying individuals aren't racist, they absolutely are, and I am not a sociologist. I've spent a fair amount of time studying these topics. And so I don't want you to take everything I say as gospel, but I do want you to use this as a jumping off point to learn more information. We need to recognize that racism has institutional power. So we hear all the time about institutional racism or systemic racism. As an individual, I can express prejudice. I can dislike somebody, but I need some system to be able to back me up so that I can behave in a racist manner. And so when we have a negative belief about something, such as substance use disorders, and we believe that they happen only to others, we view those others in a negative way. And that's what stigma is. So it's a set of negative and often unfair beliefs that a society or group of people have about something. We have a negative belief. We are stigmatizing. We make them others. We otherize them. So mental illness is nothing to be ashamed of, but stigma and bias shame us all. Again, that stigma aspect. We are looking at others as having, it happens to those people over there. It only happens to those people over there. No one I know would ever have a substance use disorder. No one I know would ever have a mental illness. No one I know would ever, or no one in my family. And when it does happen, we still tend to stigmatize because we don't want to, far too often we use stigma because we don't want to be perceived as, we don't want to have the possibility that this too could happen to me. And in fact, we know that it could. So all of this leads to bias, which is again an inclination to believe negative ideas about a group of others. All these words tend to be used interchangeably, but the bottom line is that if we give in to these beliefs, we're negatively affecting others. Again, bias tends to be negative. And so if we believe bias and prejudice and discrimination are okay and racism is okay, we're negatively affecting others. So the bias in the treatment of substance use disorders, SUDs. People were classified as needing substance use treatment in the past year if they had a substance use disorder or received substance use treatment in the past year. So that's the classification. Among people aged 12 or older in 2022 who were classified as needing substance use treatment in the past year, about 1 in 4, so 24% or 13.1 million people receive that treatment. Among the 1.8 million adolescents aged 12 to 17 in 2022 who had a substance use disorder in the past and did not receive substance use treatment in that year, 97.5% or 1.7 million didn't seek treatment or think they should get it. An estimated 0.5% of adolescents with a substance use disorder, or about 8,000 people, sought treatment, and 2% of adolescents with substance use disorders, about 34,000, didn't seek treatment but thought they should get it. Among the 39.7 million adults aged 18 or older in 2022 who had a substance use disorder in the past year and didn't receive treatment, 94.7% of those, or about 36.8 million, didn't seek treatment or think they should get it. And an estimated 0.8% of adults with a substance use disorder, 313,000 people, sought treatment. 4.5% of adults with a substance use disorder didn't seek treatment but thought they should get it. So that's a lot of information. I realize that. The bottom line is that we know that only 6% of those with a substance use disorder received treatment in the last year. And that's because of all of the bias, all of the stigma that's going into this. We know that when we use loaded words such as addict or abuser, we're implying that a person is willfully choosing to have the disease of addiction. We know that using loaded terms in the healthcare setting leads to a belief that the person needs punishment rather than treatment. These are studies. This isn't just me throwing this out there. We further know that this language makes those who suffer from substance use disorders less likely to seek treatment. And again, that arrives at that 6% of the population. Only 6% of the population who need substance use disorder treatment are actually receiving that treatment. So instead, we use people first language. Instead of calling somebody an addict, we call them a person with a substance use disorder. I have used the word addiction throughout this. That is a medical term. That is a technical term that is appropriate for somebody who has a severe substance use disorder. But when we are going into this, we don't necessarily know if they've got a moderate, a low, a moderate, severe. So we don't use that language typically. We don't use alcoholic. It's a person with an alcohol use disorder. We don't use relapsed. It's a person who returned to use or resumes use or had a setback. We don't use positive or dirty for tests. And this one takes some wrapping our heads around. I know it took me years to get it because a positive test is a negative thing and a negative test is a positive thing, but it's not a clean or a dirty test. And it's not to say that a person who has a substance use disorder won't use these words for themselves. In the rooms, they use these words a lot. Hi, I'm Guida and I'm an addict. Hi, I'm Guida and I'm an alcoholic. When they're in the rooms, that language is appropriate for them. But when we're outside the rooms, we don't use this language because we know it is leading to stigma and bias and making sure that people aren't getting the treatment that they need because we're not treating them as having a disease instead of having a moral failing. So that's why it matters. In 2022, of those age 12 or older who were classified as needing substance use treatment, only about 1 or 4 received it. Among the 18 million adolescents aged 12 to 17 who had a substance use disorder, didn't receive treatment because they didn't seek it or they didn't think that they should get it. Among the 39.7 million adults who didn't receive it, it was 94%, 5% of them said they didn't seek treatment or they didn't think that they should get it. And an estimated 0.8% of adults with a substance use disorder sought treatment. 4.5% of adults sought treatment, didn't seek treatment, but thought that they should get it. And again, why is this so important? Well, if they had cancer or heart disease or diabetes, we would be beating down doors trying to get people to understand that they need treatment, right? We don't expect doctors to diagnose cancer and then say, what you want? Get treatment, don't get treatment, don't worry about it. But over and over and over, we recognize, we diagnose treatment for substance use disorders, and then people choose not to move forward with that. That's why it's so important. It makes a huge difference. And the person first language. Our primary focus has to go to the person, not the problem or the issue. The disorder or disease is seen as only a part of the person. It treats individuals with respect, and it treats individuals as individuals. If we use person first language, we're identifying the individual first. If we use this stigmatizing language, he's an alcoholic, he's an addict, that person fits into a box with every other person we've ever seen with addiction. And now here's again the difference in this. If you work in the field of addiction and these are your people as they have been mine for years and years and years, I don't think it's that bad, right? I think, oh, he's an alcoholic, just like all these other people I know who suffer from alcoholism. But if I'm talking to somebody who doesn't understand the population, the stereotypes come in, the bias comes in, the prejudice comes in, and all of a sudden I have turned on a sign in their head that is vastly different than the sign in my head. They're thinking all of these negative things, and I'm thinking all of these pretty even things. Maybe, no real ups or downs in my world. And so when we use that person first language, we make sure that we are treating those individuals as individuals. They're not being treated as a group of these other people. We're not otherizing them. So we talk all the time about bias in testing and the testing of neonates for substance use, prenatal exposure to substances. Direct biomarker screening of neonates for substances of abuse offers a means to help immediately. If we know immediately that a neonate has substances in its system, we can immediately offer assistance to that neonate. We can offer early intervention to the neonate as well. And then we can have an opportunity for families to act accordingly and seek appropriate care and support given the information that they would have. So again, going back to my guy who had 7 OWIs, if a delivering parent comes in and doesn't realize that there's a significant problem, but the neonate is tested and there's a significant problem because any neonate born with a substance in its body that was not prescribed is a significant problem. I think we can all agree to that. We're then giving that family an opportunity to see that there's a significant problem, the opportunity to seek care, the opportunity to get more information. If we don't test because we're afraid of showing bias, we're eliminating those opportunities to actually help the neonate, help the family, help the delivering person to get the assistance that they really would benefit from. So the Antiracism and Health Equity Program at the University of Michigan Family Medicine Program said that Black newborns continue to be screened for prenatal drug exposure in greater numbers than, quote, other racial and ethnic groups, even in the absence of risk factors for SUDs. Okay, so on the surface, yeah, that's bias, right? That's actually, that's racism. That is racism, that Black newborns continue to be screened for prenatal drug exposure in greater numbers than other races and ethnic groups, even when there's not even a risk factor being identified. Flip side of that, white newborns were 24% less likely to receive a drug test than those in Black families, according to the study, but were more likely to have a drug test that's positive for opioids. Okay, so we're over-screening Black newborns and we're under-screening white newborns. And when we look at this, we think, oh, because there's prejudice or because there's racism or because there's bias for the Black newborns. But there's bias and there's prejudice and I'm not going to say it's racism. There's bias and there's prejudice for those white newborns, and those white newborns are the ones that are suffering. So what they said is that this suggests under-testing of white newborns and missed opportunities to detect and treat opioid use disorder. So it doesn't say, let's stop testing. It says, let's do a better job of testing. Let's do a better job of screening. And then let's test those infants who might negatively be affected. Unfortunately, bias is sort of rearing its ugly head and saying bias is bad, and therefore we're not going to test anybody. If we continue to test, we're showing bias against Black newborns. And that's a huge problem when we think about bias, right? Again, bias isn't good or bad. Bias is bias. We're treating a group differently, typically unfairly, but in this case, we're treating white newborns unfairly in a positive way. They're being tested less, well, the white families, they're being tested less, even though they're more likely to test positive for opioids. And I could go off on a tangent yet again. I'm not going to. It's just the result, the the uptick, the result of this is that we need to test across the board, not test at all. These are my references. There are actually quite a few of them. And that's it. That's my blog. Love for you to follow it. And thank you.
Subscribe to our channel to see more videos like this.